The only thing between us and lunch is you and lunch is us. But we hope to make it very interesting and exciting for you. And it's a absolute interactive discussion, AI in healthcare. Can I have my slide advancer, please? The sound. But you've heard the sound so many times. You know, you know what's playing. So I know. Yes, I'm very pleased to invite Dr. Mehul to the interactive discussion. So essentially what and Mr. Brijesh again. So what we'll do is we'll keep it very, very informal. We'll just move around. More importantly, we want you to ask questions, right? We are just going to moderate this. What I'll do is I just have, can I have the presentation up, please? So I have a very, very brief context setting before we kind of start off, right? So in AI and healthcare, what we just want you to understand is data can come from anywhere. It will come from the hospital. It will come from a tier 2 town, or it will even come from the community vision guardian who's out there collecting things on a tablet, or, way out in the village where they're just, using a torchlight and a thread to kind of collect information from the community. And because the eye is a feature that is an external organ, you can take a lot of pictures both in the field and also through the slit lamp, right? But then there's a lot of possibilities with data, right? So there's clinical, there's media, there's financial information also, where all the health economics and value-based care that we're talking comes from that, based on what they're paying. And also operational information, just to look at efficiency. But then there are challenges. First is, do we have enough data? Number two, continuum of data is very important, right? You just can't take a retrospective set and say, this is what the world looks like. Things change by the day. And more importantly, it's time dependent. One of the reasons why social media, the sentiment that you basically get, the banking sector and all of these big sectors that use data crunching, is that healthcare, it is time dependent. You do a surgery, you have to wait. It's not like it's going to happen in the next millisecond, right? And standardization, you will not be able to achieve 100% standardization, but wherever you can follow whatever are the global guidelines for that. But more importantly, I think the interactive discussion is going to center about the data point, which is volume, velocity, variety, veracity, and value. We'll be talking a bit of each of these things. And of course, as Dr. Praveen mentioned in the morning, descriptive, diagnostic, predictive, and prescriptive. The next thing of artificial intelligence trying to tell us what to do, what is the best outcome that probably our minds will not be able to fathom, is where the next exciting future of healthcare basically is. One of the things I just want to bring to your notice is the HKMBT, the sample size evolution that we've kind of published. H was like, if you had 100 patients back in the day, you were like a rock star, right? I mean, you had 100 patients, you published 100 patients, it was a big thing. Then you had multi-center studies, you pulled in data, got 1,000 patients to the fore. You said that, wow, there's a larger data set. LVP is in the M. M is million. B is billion and T is trillion. So our goal is, why not we talk about understanding patterns in large sets of diseases, and this is the current unique patient set count that we basically have in the organization. But more importantly, I think the AI pipeline that LVP basically has published extensively and written about is how we have come to understand the usage of AI in our digital system. So step one is that you need to digitize. Without digitizing, don't talk about AI. Number two, don't just digitize. Have some sort of a structure to it. All the NLP things that Dr. Mehul was mentioning, the challenges right now that are in front of us with just pure text and PDFs, have a structured system. The third place is where the entire world is. They're building algorithms, they're building AIs on publicly available data sets. The fourth is how do you bring it back into your EMR at the point of care. And the fifth thing is ethical and trustworthy AI. We'll be spending some time on it. Why should a doctor trust the AI? And the number 6 is the real world evidence merger with AI. That is the actual acid test, according to me. Like there's so many other parameters that you will never be able to kind of capture in terms of environment, in terms of other things that might affect outcomes for patients. But the clinical validation feeds back into step number 2, where you basically say, hey, is my model good enough? And then you go back and then, as Brijesh was talking about, building up the collection of information of the data points. So of course, Gigo, please keep this always in mind. You learned something new today. So thank you. I thought I'll set this very quick context. And now the floor is open for all questions that we can answer. Whatever we can't answer, we will open ChatGPT. With that context, let's start. Yeah, thank you. Please feel free to just stand up, introduce yourself, and just go for it. Thank you.
Hi, this is Girish. I represent a company, but we are largely into AI, trying to work a bit on computer vision using supervised learning, but I'll keep that aside. The question, there are three large areas that I want to touch upon. The first is something that was being discussed some time back, wherein we had some really nice institutions out here telling about the kind of work that they're doing with the data that they're collecting, right? I think responsibility lies with such organizations who've already crossed the learning curve. What I mean by that is, I've been in the pharmaceutical space for about close to 20 years. I've seen that doctors over a period of time are evolving. Doctors want to collect good amount of data, but they don't know where the starting point is. One. Second is, when we learn something like this from coming from somebody who's so accomplished, then what's the feeling of intimidation starts creeping in, that this is what these people have been able to achieve. I'll not be able to achieve this. Let me focus on my practice. So now coming to my point here is it not the responsibility of organizations like LV Prasad, for example, who can approach the AIOS, and through AIOS, we have a standardized system of collecting data which gets approved by the AIOS with the help of, say, LV Prasad. This is just an example that I wanted to bring in. This helps in collecting data. This becomes a collective gathering of data from across the entire country, not just LV Prasad as an institute, but the entire doctor fraternity then contributing standardized data in the entire data set. That's point number one. Should I go to point number two?
We'll answer that if that's okay, because that's itself is a. Can I take that? That's okay. Yeah. So thank you. Please have a seat. Yeah. Thank you so much for your point, and you're absolutely right. Even we are intimidated sometimes of what we've done ourselves. But let me tell you, you brought in the point of national bodies or consortiums, and let me give you a fantastic example that's evolving in the country. 2 weeks ago, I was absolutely thrilled to be part of a call of the National Cancer Grid. And I'll tell you what we've been doing for the past 1 year. So we also kind of work closely with the National Cancer Grid to set up we are on their digital board at this point in time. What NCG has done is that it's a conglomeration of 300 cancer hospitals in this country. For an entire year, we developed a set of 70, 80 national EMR requirement parameters that are linked to oncology, right? And we had the oncology experts, we had technology experts and us in the room. We used Ernst & Young as the platform to execute the assessment of EMR vendors in this country. Okay. And that went for almost 7-8 months, a very extensive exercise. Each one was given a point system. And then we came up with 6 EMRs that we believed actually were in the silver, gold, and platinum category. That's what we called. But we were sure that they would at least collect 65 to 70% of the data points. After this happened, in the call, we introduced these 6 vendors to the entire 300 group of network of hospitals, and frankly, there were close to 390 on the call that day. I was heartening for the NCG leadership also to see that. But where do we go from here, right? If I believe, how did we reach this point? How did even iSmart reach this point? It is the single decision of the leadership. We must understand this, right? You should be bold to see the truth, right? If you do not like transparency, you will never do digital health. And I'll be very, very clear on this point, right? Private practitioners, I've had private practitioners tell me, Dr. Vipin, I love your system. Can I not enter these bills? And I tell them, sorry, the system is not for you, right? So you will find this bunch of people who, you don't want everybody to be, Harishchandras and, go with the truth and stuff and everything. But the point I'm saying is, where do we go from here? We hope that over the next 2-3 years, by the way, it's a very long haul, we are able to introduce these digital systems into the NCG hospitals. Parallelly, we've also developed the data dictionary, which is a 92 parameter thing, wherein when the data starts to flow from the hospitals, it goes through the data dictionary. All of this we've been able to do because of our experience with iSmart in LVP. And we're doing the similar thing with Fernandez as well. So essentially, as you said, it is whether you want to be part of this revolution or not. We don't want to force anyone.
But agreed. But I will tell you one thing. I always tell this: the revolution will not come from the doctors. It is already coming from the society, because the society is going at such a trajectory in terms of their access to tools. When they come to healthcare, they will question us. Looks like you guys are in Stone Age. Then it will hit us as healthcare providers, right? So I'll stop.
No, but I think you have to understand one thing. It's very heartening to see that this is happening in India. That you have a cancer stack, that hospitals want to relate to each other, that you have common APIs that you're using to connect, you have common fields. You did this study. I tell you, in the US, no institution is going to share data.
Which is US is a
And Europe is the same thing. Now, Europe, if you have a national health system, this is a universal healthcare regime. It's also the data piece. Now, why don't they want to share it? Because they don't data is monetizable asset. And it's the biggest monetizable asset. So, and the challenge of sharing data are, one is greed, over greed, right? They don't want to share. So Google doesn't want to share data. Today, by the way, the largest healthcare data sits where, you know, Google, with Apple. With Apple, everyone wearing an Apple Watch. You have your healthcare data all over them, right? The Apple, in fact, is the largest healthcare data company today. You want to get good data about what's going to happen in patients and prognosticate whether this patient is at risk for an MI in 3 days. Go to Apple. It's not that company's strategy is brilliant on all fronts. Okay? Now, here is the challenge. You share data. You analyze data. Based on that data, you take certain decisions. Negative outcomes happen. Who's responsible? You share data. Use that data for clinical trial. The company comes about us. Who owns the data? We haven't solved these problems. We haven't solved the problem of data ethics. Data is biased. Who's going to check it? Consortium. What I'm trying to say is we are so early in the journey. The technology and the data is outstripping our ability to create what I'm calling ethical regulation. That's why AI regulations, data regulations have to come in the national level. There are so many issues of liability. There are so many issues of ownership. There are so many issues of proprietariness. That's why there's data nationalism. Every country wants to nationalize data. Today, India will not share its data out. States won't share their data out. You have to create new bridges. I'm not talking about India, in the US. So we are we're coming to the world where everybody realizes there is this new currency for data. And how do I audit? And we have to figure out a way to prevent that. Because it's not the new oil. It's actually the new solution to, if we have to get out of climate change, if we have to get out of healthcare crisis that we have, if we have to get out of all the rubbish the world faces, the political polarization and all, we need to have open, equitable data. And I'll just end by saying, there are political forces who don't want data out. Because when data is power, they don't want it out. They want to control the data sets. So it's really complicated. And I think if we in India can start solving it in a way that makes it equitable, accessible, and then ethical, we will run the world a great chance.
Let me take the second point and then. Sorry. Yes.
This was in line with what is being discussed. So
I believe you're absolutely right, and NHS, the National Health Stack, I believe is a move in the same direction, where the entire world becomes a community, and entire country becomes a community, and the entire data will be like Aadhaar. We will have a health card as well. At the same time, what I was trying to also talk about is this has to be a voluntary thing. As you said, we cannot force doctors, absolutely cannot. But at the same time, especially young doctors, there are many young doctors that I've come across who want to share data, who don't mind sharing data. In fact, at a few diabetology conferences, I've had doctors who've come over and said on the stage that you should start sharing data with a lot of these AI companies so that they can develop AIs which will help us in our clinical practice. So this kind of discussion is already happening today. I believe we need some good enablers. That is the context with which I came in. The second point is just a thought that I wanted to keep in front of the community here and wanted your views on it is, while we are progressing on collecting patient data, is it also not critical to start collecting normative data, which starts becoming a benchmark as compared to which we will be tomorrow be able to evaluate progress or degradation? Do you think collecting normative data in any
I have a
form?
very strong feeling here that we have to contextualize and get the ethical normative data, the ethnic normative data for this. This is a big global bias that a lot of therapeutics is based on studies never done. And something published in a journal that has, I did a lot of work in Africa and COVID, and I would work with name the two of the big foundations, and they would say, well, this is what it is, and we need to do that, and we need to give sewage, assessment of COVID and all. I said, we don't have toilets. Has anybody worked in the front line? No, but this was published here in this. I said, which person in Rwanda reads your paper in JAMA? And you set up a set of standards there, what difference does it make? See, this normative relevance is not there. And unless we create what it means, somebody mentioned very correctly here, look at A1C. Okay, run an A1C in the US and we are all pre-diabetic. Because our WBC is a little bit different lifespan. We haven't indexed it. This is a small example of so many things. We should create a national normative data stack, and it's not that the North is the same as the South. We are such a diverse country. And if we do that, our clinical treatment will be more relevant, our treatment will be more relevant. What LV is doing is yeoman, what everybody is doing here is yeoman work, right? I mean, the things that are coming out, this is our goal.
Exactly, absolutely.
And I'm saying that we have to recognize and invest in this. ICMR has to build our stuff, build our normative data stack. I'll leave you with one thing. A close colleague of mine is the vice chair for neurology at Mass General, Indian origin guy. His father is one of the oldest neurologists in, most established in India. And he ran a stroke study with 9 Indian institutes. Dual funding, Indian government funding from there. And he found that what is the benchmark against which they look at stroke outcomes? Not the hospital benchmark, but that's the only benchmark we had. So PGI was there, AIMS was there, you name it, CMC Vellore was there, top-notch institutions. There are lots of problems. This is a great example of a two-country study of how really it was 2 one-country studies. And so the cross-fertilization did not occur.
I'm sure.
And I'm saying this is one of the many problems. There are many, I reported the study for many reasons, but to me, this is where cross-fertilization needs to take place. We couldn't share data. There were no data sharing agreements. So each country was keeping their notes. So how do you do a joint study now if you're doing cross-country, right? There were many of these things that didn't work out. But your point is right, you have to create, what is our normal data stack? I leave you with the last thing. Every lab here uses some equipment made by some foreign manufacturer. They are indexing the normative values. Not labs do now try and run an index. But their reagents are based on that, their tests are based on that, the ELISA is based on that, the immunochemistry is based on that. So whereas bias is widespread, I see bias all over. Right?
Yeah. So sorry, just to quickly add on Dr. Mel's points. You're absolutely right. Even before normative data, India doesn't even have pathology data. And I'll tell you what we've been doing from ISPOT for the past 5 years. Absolutely, put our heads down and we said, let us now profile every single eye disorder. Let us see the descriptive stat of every single ocular disorder that there is. And you'll be surprised, 65% of those papers did not exist. And you have to build it step by step. And just to quickly kind of say, if doctors say, I want to share data and stuff and everything, well, you can't do much with, say, 10, 20 and stuff and everything. But consortiums like this, to be able to kind of bring together this common narrative, right? And it has to be built year after year, year after year. And then we all come to a point. The goal is, can we have a Bloomberg or a McKinsey report like that from IHOPE someday? Which says, if you want to know what's happening in digital health in India, go to this kind of a group or consortium and they will tell you what is the current scenario and stuff. But no, I'm not saying.
Right.
No, I'm not saying. I'm saying. But yeah, please, Brijesh, please.
So, to answer your question, should we? Yeah, simple yes. The question that we have to ask ourselves is how, right? And the difficult part is answering that how. Different people have different points to go about it. You have different ways to go about it, and so on and so forth. The one thing that I usually ask people is when they publish their papers about based on some sort of a research or whatever is your research reproducible, right? If your research is not reproducible, then it's as good as trash. Trust me, my papers are trash according to me because they're not reproducible right now. It's just hard stats that I've produced in the mentioned in the paper saying that my data does this, and this. For all that I know, somebody could come and question. You probably have just come up there with those numbers. All of the 6 years of research that you did is just nonsense. Those numbers are made up, and I don't have a way to prove that. Right? So when we talk about data, when we talk about normative data, when we talk about all of these things, one of the first things that came out in America in 2018, I think, was a paper questioning, hey, are algorithms biased racially? Right? Everybody lost their mind. There was a political fallout to a certain degree. Fox was saying something, CNN was saying something. All of these people were like losing their minds on it. That is when people started looking at, okay, if we apply these algorithms on these kind of cohorts, are we getting the outputs that we should be seeing? We ourselves did that. We started looking at it we stripped out the whole, we never used race or ethnicity or whatever, or language or whatever, but we started looking at it from a standpoint of PA1C. We know where are people being predicted, what is their prediction in the next year, so on and so forth. Then we applied race and ethnicity to it. How many of them were white? How many of them were black? Clearly, it is predominantly white driven because 80% of our population, when I say our population, Florida membership is white, right? So the kind of data that we get is for them. Now, the second point that I wanted to make is, we talk about AI we have to talk about AI, because if we talk about analytics, it's so in the past. But the fundamentals of AI come from very, very strong fundamentals, statistics. It is the underpinning thing. People lose their sight over AI, LLMs, and my own company is doing that right now. They talk about NLP models as legacy. I'm like, how can you call LSTM as legacy just because you have you have an LLM, which kind of does a very similar stuff, except that it uses a transformer, right? Legacy, which was like last year, but still the company runs on fundamental analytics to this day. So when we talk to our clinicians, when we talk to our care providers, they ask us fundamental numbers. They don't care about what we predict. We had to actually explain probability to our nurses. We had to tell them that, okay, when I say probabilistically, I'm saying 80%, this person has a chance of risk. We had to explain to them what. We had to bring that down to ventiles, because that's how the NCQA was designed, 1 to 20. And we had to say, if the member has 19, that means to say a very high risk. If this member had 10, medium risk. If this member had 0, low risk. So on and so forth. You have to work with those things. So I would say that, no matter what you do, you have to ask yourself what you're doing with the data, how you're going about it, and start off with the fundamental statistical analysis, which is supposed to be very rigorous and thorough, and it has to be reproducible. Otherwise, there's no point. So when you build your dashboards, when you build whatever, right, everybody can just come in and say, okay, hey, this is what it is. But what is the thing that is underlying that? Because numbers can be represented in any which way, hence the bias. They can be collected in any which way, hence the bias. I can be just a data point. So you'll have to take it in context. That is the question that we have to ask ourselves.
Thank you. I request our panelists to also use the mic so that the online people will be able to hear it a little better. Great. So, yes, did you have a question, sir?
Yeah, I did.
Yes.
Then looking at the digital strength of our country, both in the last decade and both in digital payment platforms and everything, I think in 2020 during the Independence Day ceremony, Prime Minister Modi talked about digital iCard, right? And health card for all.
ABBA ID, yeah.
Right, ABBA ID. Is that has there been discussions, because we guys as smaller researchers or small, we don't know, but you with your connects, has there been discussion engaging clinicians and looking at how this could be driven into a national level data that we are discussing today? Has there been any discussion, any updates around that you can share?
Great, I'll take that. So we're very closely working with the NHA. Please have a seat. Yeah. So essentially, NHA has given a sandbox, right? And there's M1, M2, and different stages on how they've asked all EMR vendors to basically ensure that an ABBA ID can be created for a patient. Now, the government says, as part of the National Health Stack, we will have a certain set of variables that we will store. And through the permission of the patient, we will then hand it over to another hospital that will have to basically read from it. So that's all the interoperability thing that's there.
So with regards to onboarding, well, there are just a handful of EMRs that the government is now kind of endorsing that they've completed the entire ABA ID. Even the NCG's initiative, we've asked the EMRs to get their ABA IDs done, right? I mean, just to kind of see, the point is, if you have to release a white paper, just because somebody else has released a white paper, you can release it. There is a National Digital Health Blueprint that got launched in 2019.
Right.
We all know where that went. What is more important is, let's focus on creation of systems first. Then we can always get into what is the broader area of.
So my question was, is that a valid platform to build upon what we aspire to
No,
do?
definitely. I would suggest that if the government basically very proactively and very constructively, progressively is creating certain protocols, we should kind of probably go ahead and then try to map them, right? I mean, if it works out, it works out.
Right.
Right. But again, my only argument is what percentage of our institutions are digitally enabled
Yeah.
for them to kind of, see you create an ABA ID and then it goes back to paper. What are you going to do with it? Will you upload a PDF?
Yeah.
We'll go back down the same unstructured data and then get back into discussing NLPs for India in 5 years from now.
I agree.
We don't want to go down that path, right?
Alright.
So at this point, I'd like to actually ask Anand, also Anand is from Remedio, one of our collaborators as well. So Anand's group has been doing some phenomenal groundbreaking work in diagnostics, right? So there's diagnosis. We've been speaking about a lot of diagnosis. There's diagnostics, then there's data. We've been talking about it, and there's decisions. So the 3 Ds that I want you guys to kind of keep in mind. So I'd love Anand to kind of spend maybe 5 minutes quickly to share some of their work in Remedio, and then probably ask us questions.
Just tell you that, we look at India and we look at the US, but there's a lot of the world is there. And other parts of the world have addressed this, and look at what is happening in South Korea as an example. Or look at the NHS is one example. Look at the Canadian states. I work with Ontario. I'm working currently in South Korea. They have actually created data ID stacks, and everybody carries a single medical ID. Now, in no country's journey was the country digital from the start.
Agreed.
So these journeys are in parallel, and digital conversion of unstructured to structured data conversion is not going to happen 100% ever. So technology has to solve it. And there are new, lovely, amazing technologies that they say, is it data or is it somebody's intuition? As long as it's out there, we don't care what it is. We will take that input in and we will get it. Now you have to scan the original data stacks and all. There's some work to be done. But now it's becoming such that you're not fighting against this to create a single data lake, but you're saying wherever they exist. We will actually collate, draw, and then we will actually analyze from there. But we are going to create a national individual data ID. And that is where I think you'll find the power of a country coming in. And it's happening in other countries in space.
Yeah, that explains why I'm able to only compare some of the South Korean papers because the kind of similar numbers that they have is a national set of.
So much, but I won't take too much time in terms of about Remedio. But what we've been doing is, how do you take eye care to the last mile to public health centers, and that's moving devices as well as interpretation or triaging algorithms. So they could be AI, they could be much simpler algorithms. And our learning really has been that being a technology company, the easy part is the technology, right? But really, how do you actually get it implemented has been a lot of our learnings and lashes in the back in terms of coming from the demand side, right? From the patient side upwards rather than technology side outwards. So if I were to just summarize maybe what Vipin talked about in terms of our learning, one is how do you build programs around technology rather than just thinking about technology by itself has been a great learning. And the second is simplicity in how you do this, because in a place like India, if something is not simple, and the example was a RAP survey, right? It was simple and therefore could be scaled. And so with a lot of technology, we run the risk of making something a little more complicated than it should possibly be from a public health perspective. And the last part is really about, we like to call this, how do you sort of eliminate, and that was where my question was going to come to, is the data silos. For example, we learned from our own learning that you can build models with nice data that comes from hospitals taken by exceptionally good optometrists and ophthalmologists. But now a nurse or a allied health worker or a ASHA worker is not going to take the same quality picture. So you'll have your AI algorithms reject that for quality each time, and you really can't have that impact. So coming to the two key questions that I had is the beauty of a consortium is I feel that if we can also start asking the question of what is the problem we are trying to solve, rather than necessarily the solutions, and therefore the data, etc., comes once you're clear on the problem that you're trying to solve. Right? We made this mistake ourselves where we realized that in the US you may have ICDR that has stages of diabetic retinopathy, and therefore, if you see it got defined as saying, can you detect more than mild diabetic retinopathy, right? And there are certain reasons why that has been done purely from an economics of it perspective. But from India, is that the right problem to look at? Because the way the treatment is done and where you want, we have diabetologists as well as ophthalmologists telling us, no, mild is equally important. Can we pick those up early and can we move them to standard of care? So the question therefore is there a way by which the consortium can get together to have thematic problems that need to be solved, which may not be the same problems as the way they are being defined externally outside India, right? For example, you may not want an AI model that is about detecting diabetic retinopathy, because when we go to public health, the first thing that the patient tells us is, oh, you only detect in people who have diabetes, who have an eye problem, whereas the multitude of people who come to a primary healthcare center or a public health center are going to be people who have lots of problems in the eye that they want to be actually looking at. So that was the first part of the question. How do we as a consortium, that includes us as well, in terms of defining the problem? The second is to the question where there is never going to be a case where the data sharing is going to be that open or that equal. And so the question really to Dr. Mehta is, just as let's say we went to the mobile phone revolution rather than going with the landlines, you think therefore the future is about looking at federated models where then the models are shared rather than the data being shared? And is that where maybe India can talk leapfrog, because there is data here, but the way we share data is not in terms of the data itself, but start sharing models around the data. And then that starts improving the model, and that is, it preserves privacy, it preserves everything else, but then maybe that's a way by which we get ahead to what is otherwise being a stopping point, at least in the West as we see. So sorry for the long rigor.
So let me answer, I don't want to dominate the conversation, but I can try and answer both. Your first question is, can we actually frame the problem correctly? Let me tell you, it's a very important question, and we talked about clinical research. Let me tell you the flip side of what we are seeing now. You know what to ask to frame, because you make a set of assumptions of what you think is going to be the way you get a solution. What we are finding in many of these large data analytical platforms is totally unexpected things that you never even imagined to frame in the question. Like, do you ever imagine that by analyzing a retinal fundus, you could predict cardiovascular risk and Alzheimer's? You could never imagine that, but that did come up. So I would just caution by saying, let not the framing be your right line, but let it be a directional line. Be open to what the data will tell you, because the tools today we have can extract some phenomenal information that will surprise us. And the information on race has been the biggest eye opener. I'll give you the race example, which will shock you. Again, an MIT project. They did a study to drive the result. They wanted the result. They just wanted to test the system. So what they did is, can it analyze this X-ray? And they completely contaminated the X-ray to get a negative result. So this is a negative study, just to see if the technology consistently produces a negative result. Nobody can read that X-ray, no radiologist, and it's all noise. The machine said that this is a lactation, consistently. Race was never in the EMR. They went back and found the machine was actually right. Where did the machine, the algorithm, get an analysis beyond seeing anything? Because this is all from pixel level. And then the question is, when the algorithm is giving a direction of how treatment should be done, how much is the fact that the algorithm analyzes as black coming in, factoring in? There's bias within bias here. And this is unmasked bias that was masked. So when we build this, we are also getting into the space where it is intelligent, it is doing its intelligence in ways that we don't understand. So just accept it. To your second question of silos, we're never going to break silos. Silos are a given in how medicine is structured, it's how we train. We have to retrain ourselves if you want silos to be broken. I'll ask you a simple question. In the first 2 years of medicine, why don't physicians, nurses, and physiotherapists train together? You're going to train as a team, no? You're going to practice medicine as a team. So do your first 2 years together. It'll never happen, right? Because we have a hierarchy. When we start with a hierarchy, you'll end up with a hierarchy. You start with a silo, you'll end up with a silo. So what is happening today is that systems are coming out that are actually asking the question, what is the information that you need? What is the signal you need to look at? Or what is the relevant signal? Let it process across multiple data sets, all siloed, structured or unstructured, and give you relevancy in the signal. And the signal relevancy is all that matters, right? Because then it tells you these are the 3 things to look at, 50 other things don't matter. Now, that's where we are moving because medicine has all forms of data. There's valid data, invalid data, confusing data, half data. And I don't think we're going to solve the problem. So if utopia doesn't exist, then you create a solution to extract from whatever exists, the reality that exists. That's what I see happening.
Vijay, a few points.
Yeah, I'll also add it here.
So yeah, I wanted to talk about silos as well. India is in a very interesting space when it comes to trying to see if you can not really bridge the silos, but kind of close the gap. There's a very nice paper when cloud was in its nascency, called Hey, You Got Off My Cloud. So they were trying to identify how usage across different servers was happening, and they were all siloed. Right. So from that standpoint, if you want to look at it, you have to ask the right kind of questions, like what am I going to use this for, and kind of bridge it up from that standpoint. You're never going to actually make it because you can't look at the American model, you can't compare it to the Indian model because it's completely disparate. As Dr. Mehta was mentioning, there is practically no way you will get information or data shared between different players in the market in America. You'll probably pry them off their dead hands, but then you'll jail for that. So it's not going to happen. Will that happen in India? I don't know. It depends on a lot of factors. So that is one aspect. So the other aspect of can we share models? Can it be used? Yes, there is a kind of approach that you can use. You can build models. You can trickle down the streams, and then you can build more on that. Have other algorithms come in, they'll have their own spare usage or something of that sort. So it depends, but then again, it depends upon the variability of the data that you're looking at, right? It's different in America versus different here. Probably the usage is very similar, the issues are similar or whatever. So it depends on a lot of those factors. Do you actually need to use that transferring approach to further these things, or can you just use an off the back model, which is open source decently enough, which is looked at by different people, run against different data sets, and so on and so forth to test for its robustness and stuff like that. You can probably do things like that, maybe. But again, it's something that needs to be seen. It's a playground on its own. There's no hard and fast answer where you can say, hey, that worked there, so this can work here. I don't know if you can do that.
Yeah, thank you. But I will answer Anand's first question. Do we know the problem that we are asking? At our lab here, we are very clear on 4 specific, as Dr. Mehul mentioned, it's a directional line. It's not like a hard drawn line. Step number 1, understand what the burden is of what you're trying to solve, period. Let's not go around the bush. I think this is this, I think that is that. Let us see the data. Let us understand the burden. Number 2, let us understand what you're doing, what you've done to solve that burden, medically or surgically, right? Step number 3, look at outcomes, because now we're all talking about outcomes. There are very few organizations that talk about outcomes, and even at LVP, we have internal outcome monitoring, which we're planning to slowly make it public also in due course of time. Number 4 is where the machine will tell you, doctor, you're picking the wrong surgery. If you don't have step 1, don't talk about step 4. Right? So 1, 2, 3, 4 are very well defined now. For the past 5 years, we've been putting our heads down to 1, 2. We are at 3 right now. But we have to generate enough 1, 2, and 3 to ask the questions for step number 4. Might take a year or 2 more, but we are on that path. Yes.
Please.
Just to give a little context, we are a technology company in the AI healthcare, and we are marketing a UK product. It's called Avatar AI.
the question is, we are successful in marketing this particular product in South America, England, Singapore, everywhere. And we have got a clinical data that this is the care plan management software, which is AI driven, both at the patient level and doctor's level. Raffles also we have implemented in Singapore. Now, everywhere we have got a study done where it proves that 20% of the doctor's time can be saved if our software is used. I got all the data. But now, for the last 3 months, we are struggling in India to market this particular thing. So, doctors like it, and I have several meetings at Nanavati, KEM, KMC Manipal, Ruby Hill, everywhere. Okay, we are Bobby-based company. Now, doctors like it, clinical staff like it, and we have given the demo to the board members also of all these hospitals. Now, what is stopping here is final decision. So, I'm failing to understand when we share this particular data of reducing 20% of the time of the doctors, why there is a delay from the management in approving this AI-based software. Is there any policy?
I have one answer to that. So thank you. I got your point. It's cultural intelligence.
Okay.
You must understand that cultural intelligence is everything when it comes to technology. In how a population seeks care, how a population traditionally has sought care, and how the care providers and their position in the particular society bears a big thing. And I'm pretty sure that other regions where they'll be more adaptive to your care is one bit of it. But again, there is no one answer to it. But I've been always relevant because now iSmart is going to different regions of the world. Cultural intelligence is everything for me, right? And we are going to regions where no one will go. We are not an IT company, so we will go to regions where we are going to definitely add value to eye care. That's what our mandate of our founder chairman is. But cultural intelligence is a very big thing. I think you should let it evolve and be happy with whoever uses it. That's all. I mean, yes.
Just answer your question because you have mentioned multiple countries. Yours is a chronic disease management platform.
Culturally.
A chronic disease management platform in the US is called population health management. What is the basis? What drove chronic disease management to be adopted? We had it for a long time. Why do countries want it? The reason is that reimbursement is moved in a way to say that it's what you call a partially capitated model, that you are looking after a group of patients and you're given a set of money. If the patient falls sick, it comes from the pool of money we give you, right? Therefore, now you're incented to keep the patients well. So we also have the similar models in the US that are working. And we get a separate reimbursement for population health. There's a financial incentive to make sure the patient stays healthy because you are rewarded for it. What is the financial incentive for Max and Ruby to make sure the patient stays healthy? What is the financial incentive? They want the patient in, no?
Yes.
So the answer always comes down to money. At the boardroom, the cultural awareness for them is only one thing. And that is the culture that unfortunately we have here. In Singapore is a capitated model, very simple. I can tell you in all these countries. That is what has made population health. President Obama did this for a reason when he brought it up. He knew that unless, the number one driver of physician behavior change, the number one driver, financial incentive.
Thank you. Yes, ma'am, please.
So when we use GPS in the car, we keep using it, we actually forget the path, right? Without a GPS, we can't drive. So as a surgeon, and as well as with such an extensive, work experience in AI, do you think continuous use of this AI is going to make us less of a doctor in terms of algorithm and decision making? Because I think that's the skill we learn over the 5 years, to be observant and to make that decision tree. So I'm just concerned because he also said in the morning we can finish our professional training in 3 years instead of 6 years. Are we moving away from giving that human touch that we have to learn and not utilizing the brain, which actually
I'll just take a quick dig at it and then go to Mehul and Vijay. So I think we will go in these phases. Phase 1 is we'll bridge the gap of human understanding. Definitely. It's a huge benefit for us. What we are not able to fathom, what the machine will be able to fathom, will definitely be beneficial for the patient. Phase 2 is lack of human understanding. Loss of human understanding. We might lose it. I don't know. I don't know. Because today you will never go for clinical examination, you will write a test for a machine.
Yes.
It's already happening. It's not that it's not new. I think it might get worse or better. Only time will tell. Maybe 12th edition of IHOPE conference will be discussing that. Greater detail. I'm pretty sure. Dr. Mehul and Brijesh, we can get your thoughts on that.
Yeah, so I feel you when you say that, will it take over or whatever. When ChatGPT came out and then there are people on LinkedIn saying, GPT can do all of these and machine learning engineers can do. I thought, what the hell? So, but then if you think about it carefully, right, every technology has disrupted the way we learn things. Internet has done that.
Yes.
Without internet, we wouldn't be here the way we are talking about it, the access that we have to whatever. And if you think that ChatGPT, whatever, is super intelligent, its performance has actually gone down since June.
Okay.
Yeah. So, and it's gone down because of the way it's continuously learning and the way people are doing certain things. So there is a lot for us to understand how to use it. So, simple question, things like there are people in my team who were our users, first SAS users, then became our users, and now want to become Python users, and they want to learn it fast. And they use Ask ChatGPT very specific prompts and questions, and that helps them. That doesn't mean that they'll become less good statisticians or the way they look at data will be less. It just at the end of the day depends on how we use it. You seem to be an actress, you think about the patient or something like that sort, right? Maybe another doctor does not look at it in that kind of thing. No matter what tool is given to you, you will always use it for the good in the right way, right? And so it just depends on who we are, what our importance is. If you're able to get a degree 3 years in advance or something like that through an advanced use of technology, so be it, that's fine. But it's all about how we eventually use it. And again, this notion that AI is going to be so transformative will probably not hold through because we truly do not have that kind of a data. The way OpenAI is collecting all of the data to feed in to ChatGPT is ethically questionable.
Yes.
Right? Now, same is the case with Llama. We do not know how the data was captured. There are so many other models that are fed data. There's a lot out there. I personally use some of the in these algorithms to try and do a few things, and some of them are the answers are really dumb. You can't really get the right kind of context and stuff like that. So from that standpoint, there is a long way to go to that. So
and to summarize, Brijesh, a fool with a tool is still a fool.
Fool.
I completely agree with Dinesh. There is all these models, the way they are learning, there's lots of other negative issues that ChatGPT produces. Credible garbage. Like credible garbage is out there, and and all the conspiracy. So there are lots of things. But what we have to accept is the following: we are at a transition in where we do work, and where we actually apply our knowledge and skills. What I think, again, everybody's crystal ball gazing, but when new technology comes, things where human capacity was used that are routine, operational, replicable, which is unfortunately a bulk of where employment occurs, will be jeopardized. I believe there will be a premium placed on human intelligence and experience, and premium placed on those professions where human-to-human contact is critical. And those things will actually unburden us. How much of your time in the work that you do is work that you wish you didn't do? And if we can decount that away and give you time back to do work that you want to do, that to me is what is going to happen. I don't think that this world will ever be run by automated robots, but I do think that it will become more efficient. But that means that countries like India have to rethink what it means to a manual laborer.
Or have 4 days a week, work week.
4 days a week.
Let's talk to our bosses, sir. Nindya, please. Quickly, we have just a few minutes, so of course we have the entire lunch to continue to discuss, but Anindya, yeah.
Yeah, hi. I'm Anindya Chakravarti, the OPI of IHOPE now, and I'm an economics professor at IIM. So the reason I wanted to talk a little bit about connecting these two questions that were raised, this is not a like a question that I'm posing to you. It's more like a remark to catering to those questions. The first question was about the acceptability of certain forms of avatar kind of a thing to patients and doctors, and why it doesn't fly. The second one was whether the human touch is getting lost or not. I'm not a doctor. I'm just simply I'm the useless doctor, the economist one. So I was very curious when I started talking to Dr. Raja and Dr. Vipin that when I got to know about the EMR system, I thought that it's a no-brainer. Like everyone should do it as an outsider, right? But then I get to know that there are frictions from the point of view of doctors as well as patients and so on. So I went back. I was teaching a course and I was in a room full of physicians, practicing physicians. So I just ran an informal survey. Why don't you adopt it? Like, what are the frictions that you see? Among a lot of other things that one can theorize from outside, one of the strangest thing, at least to me, that was one of the strangest thing, was that they were saying that wherever we are seeing our patients, if they see us that we are typing on something, the patients think that they are not getting money's worth of attention.
Exactly.
So the patients kind of freak out and then say that this doctor is worthless. He's not even attending to me. So it kind of answers it at one level in the sense that people do actually fear it now at this. So there are two versions of it. One is that this is called the human-computer interaction that is evolving over time. And here I think I completely agree with Dr. Vipin that this cultural intelligence about how we perceive certain things that is evolving over time. So my parents cannot even imagine, they are very afraid of transacting on like GPay or Paytm. But now the younger cohort will be perfectly will find it legitimately usable apps. So the acceptability is changing very, very rapidly. So much of the changes earlier, the way the curves were moving, I mean the acceptability, now it's almost skyrocketing. So the slope itself has increased. So it's almost like the double derivative is now positive. So one is that. The second one is in terms of, I wanted to react to your point about losing this human touch. So nowadays, so for example in Japan, I know that there is a lot of dearth of nurses. So what they are trying to do, and there is a company in India as well who are trying with robotic nurses. Efficient during COVID times, obviously it's better because you're avoiding human interactions, but then people freak out looking at something robotic coming in and holding some medicines and then saying that on the chest of the robot it shows that now drink it or whatever. Maybe we will over time we will get adjusted to it. All I'm saying is that right now it's quite possible that we still want some kind of human warmth when we go to a doctor.
Yes.
Now over time that might change. But I mean, two things are simultaneously true. One is that at a very massive rate, human-computer interaction mode itself is changing towards the idea of having more and more substitution and less interaction. And that is where a very simple demand-supply model of economics says that if the supply of human contact goes down, its price will increase. And that is where I think I agree with Dr. Mehul, where he's saying that whichever job profiles are there that will put a premium on that, their prices will increase and their returns will increase. So it was just a, I guess a way to connect some of these, dots, and just wanted to share my.
Thank you. And I just want to kind of add, thank you so much, Prof. But the way I've looked at it, in terms of how technology has evolved, because it's all imagination here, you can just let it run wild. 1960s, Star Trek used a tricorder. The tricorder could do anything, right? And Professor Ramesh at the MIT Media Lab started off a project to actually build a tricorder. See, the point is, you imagine the most ideal way of doing this. And I strongly believe all the Hollywood movies that show where healthcare can go in terms of just putting them and one, kind of a CT scan can go and then operate them and they're out and stuff will happen someday. All I'm saying is that it's good to dream, but also be mindful that we are the ones who will have to build that dream. Right? So it's kind of in continue.
Yes, one last, I think, because it's.
No, I'll
12:59.
ask you question as question only.
Question as a question.
Yeah.
Most cases,
So now,
question.
now people are talking about AI and other stuffs. So maybe it can last for another 10 years or maybe 15 years or maximum up to 2040. Then what next? Can we think of something integrating human intelligence with quantum computing? quantum
Generative
computing
intelligence
with
is
cloud,
what's coming.
Something like that?
AI, so it is generative, but GI is GI for me, like gas. I don't know much. But then, Dr. Mehul,
I don't know.
I don't know. I don't
But
know.
I just come back to Stephen Roosevelt because when he was talking about AI in 1970, and then he moved on, he talked about generative and all that. So what is he doing now? That's what I call it. Because I think the man is just, he's one of those people who thinks like Albert Einstein thought. The whole theory of relativity came because he was watching a train and the whole theory is in his head. This is how Stephen Roosevelt thinks. So when I looked recently, I have to reach out to him. So what is he actually studying right now is mathematical models of consciousness. That is something that really pushes the extreme. Mathematical models of consciousness suggest that if you can actually create consciousness systems, I don't think the math is up there right now. Although, and then you can translate it. Then what do you do with machines? What do machines become when you imagine machines with consciousness?
Spirits and machines is a big thing, yeah.
That is now taking it to a different space, and that becomes humanoid. So Star Trek becomes real. But it's real, it's happening, that's what he's studying. So that's all I know about the future.
Great, that's one last comment from Vijay.
Yeah, I mean, if you've heard about that code precision, do electric sheep's dream? Nobody really knows the answer to that, right? So AI has been there for a long time. It's just that we're able to apply it right now because of the compute power that we have. To call AI is to say that ML was or statistics or whatever, even operations research for that matter was obsolete. It's nonsense. But it's still going to be there. There will probably involve the human conscience to be able to understand that there are a lot of things. Man is trying to become God in a certain way. So maybe we'll go there. So, yeah, I don't think you can actually really answer what can happen in 15 years from now.
No. So I think we'll have to bring it to a close. But again, we'll come back to the sentence: "Man becoming God." But in God we trust. Everybody else bring. Right. So with that, we'd like to kind of close the panel. Thank you so much, Dr. Mehul. So please do join us for lunch. They are still around. Continue to converse with them, and we'll come back for the. Thank you so much. And please kindly assemble out for a group photo. Here. Sorry, we took one outside. We'll take one here now. Can we request everyone to please come to the stage, the dais, for a group photo?
That's a good shape.
Can I request everyone to please come to the dais quickly so that we just take a quick group photo. You can stand in 3 rows, starting from yes, it's just stand in 3 rows. Yeah, step by step. That's what I think. 3 rows, I think it's. I request everyone to please quickly comment on the group picture.
We're going to go even more.
No, there will be an existing so there is a report that's currently this kind of goes on. I run a report data science at IIM. And we did a report with BCG with 30s of the companies to adopt this technology. And
There are too many outliers. Can we just please kind of
We can come
get in
down.
one more go down?
One more, just one.
Make sure your head is between both 2 heads. That you're seeing. Okay. This is AI.
I'm just
Precision. You come this side.
Just come between me and Dr. Acharya. Yeah, no, you are stay. All right?
Yeah.
Thank you.